Thank you, everyone, and thank you for being here to listen to me, and thank you to SEGM for inviting me to speak and talk at this conference. These are the areas I hope to be able to cover in my presentation today. I'm going to commence with some brief background on how I became involved in this topic and the situation in Victoria, Australia, where I come from. And this background probably parallels some others from other jurisdictions. It was around 2018 when I became aware of the new vogue of recommending early childhood social transition for children with gender incongruence. A parent of a 4-year-old child challenged me when I explained to her that most children with early childhood gender dysphoria, it resolves and many end up becoming homosexual adults. And I was told that the Royal Children's Hospital Melbourne does not say that. I was actually doubtful about her statement, but when I turned to the Australian guidelines, or the Royal Children's Hospital guidelines, I found she was correct. And indeed, an editorial in The Lancet that year trumpeted that the Royal Children's guidelines were progressive in that they suggested the child should lead the decision to socially transition. And the Royal Children's Hospital is arguably the most prestigious medical institution in Australia. Now, other Australians from other states would argue against this, but the important point is that almost everyone trusts the RCH. But I decided to evaluate these claims in the guidelines for myself, and that has turned out to be a longer and more challenging journey than I thought. To give a brief summation, my first reading, I was immediately concerned about several aspects, and the more I read, the more concerned I became. They seemed not only overstating the evidence, but also misrepresenting it and the clinical consensus for the mental health benefits of social transition, as well as the other gender-affirming treatments. They omitted information on limitations of studies, and they did not discuss the evidence that most children with gender dysphoria would grow up to be homosexual adults. And some of the citations just did not support the claims being made. So, for example, they cited Jack Dresser, an article by Jack Dresser from 2013, to support a claim that psychological practices attempting to change a child's gender identity to be more aligned with their sex of birth may cause lasting damage to the child and adolescent's mental health. But when I went and looked at Dresser's article, what he actually stated that there's no empirical evidence in support of this claim, and that clinicians are divided, with some criticising the approach of affirming the child's cross-gender identification because of concerns it would lead to early medicalisation, while others criticise an approach that works with the child to decrease gender dysphoria and cross-gender identification, and making this analogous to conversion practices. And he was adamant there was no empirical data. So to be crystal clear, I'm not arguing for psychological approaches that aim to change a child's identity. Rather, the issue that I'm highlighting is that the RCH guidelines misrepresent the evidence on this claim. Now, many of you here will be unaware that Victoria introduced conversion legislation in 2021, and this has had a chilling effect on mental health practitioners who recommend a cautious approach to childhood social transition. And this section, as you see, defines a legal change or suppression act as and it can be a psychiatric or psychotherapeutic approach that is directed towards a person with or without their consent for changing or suppressing their gender identity. In 2021, I think that's right, I wrote to the Commission overseeing the legislation, and I outlined a hypothetical clinical case where the parents did not want their 6-year-old child to undertake full social transition, and I supported them in this as described by the Dutch clinicians only a few years earlier in what they described as kind of a middle road approach. And I asked the Commission, would I be in breach, I or the parents be in breach of the conversion legislation by not supporting full social transition? And after a bit of pressure on my part, the Commission did answer and wrote to me saying the suppression will likely mean a practice or conduct with the person of preventing someone from expressing their gender identity rather than the purpose of delaying or postponing. However, the meaning of this term would be a matter for judicial interpretation in the future. So it provided some reassurance on one hand, but on the other hand, an anonymous report could be made and the parents and I might have to go through the gruelling process of inquiry in court, the final outcome of which was uncertain and could include up to 10 years in jail. And Origin is a well-respected Australian youth mental health agency that receives a large amount of government funding. Its educational material for clinicians, publicly available online, include this section stating that parents who deliberately misgender their children are committing a violent act. And for those who are not aware, at risk is code for referral to Child Protection Services. So parents who do not agree to fully socially transition their gender incongruent child fear Child Protection Services knocking on their door. So no wonder in Victoria many of these children and parents struggle to find a cautious and exploratory psychological and psychiatric help they need. Maybe I should have done this slide on definitions earlier, but social transition is one of the key interventions of the gender-affirming treatment model. And broadly, it refers to social changes such as name change, using different pronouns, and appearance changes so as to live socially as the experienced gender rather than consistent with one's natal sex. And this can be a full social transition. So, for example, for a binary gender identity, a full cross-sex identification in all settings, or it can be partial and only in some contexts. And it's not just sex stereotype non-conformity. It's not just I'm a boy who likes girls' things. It's what's typically associated with girls. It's I'm a trans girl or I'm a girl. I'm going to focus on full social transition in prepubertal children, but the studies and systematic reviews I discuss also do cover adolescents and often note that whether it's full or partial social transition is poorly defined by some of the studies. Giving an overview of changing approaches to paediatric social transition, the rationale to socially transition or not, I would note that until recently there was a great deal of caution about this approach. The Dutch in 2012, WPATH SOC 7 2012, and the Endocrine Society Guidelines 2017 all took a cautious approach to prepubertal full social transition. This was because of the evidence that most children with gender-related distress is resolved at or during adolescence. There were reports of some children who had fully socially transitioned and found it difficult to revert back to an identification with their natal sex. Plus, it was observed, the Dutch observed that the young children could develop a sense of reality so different from the physical reality that the acceptance of multiple and protracted treatments that would later be needed is made more difficult. That's the WPATH 7 SOC statements on this issue and the endocrine guidelines. Because of time, I won't go through those in detail. I'm just mentioning this issue of childhood gender dysphoria and homosexuality. Rona Knight, 2015, Alexander Corte, 2008, and some of the UK GIDS clinicians have raised concerns about gender dysphoria as either a phase of homosexual development and or the impact of internalised or external homophobia leading to a wish to transition to the other sex. Rona Knight's a United States Boston psychoanalyst, and she wrote this in 2015, basically outlining that given the concreteness of children's thinking, the lack of language to express their homosexuality, and a homophobic society that is unwilling to think about normal homosexual development, that homosexual children could arrive at the mental health professional's office with gender dysphoria and not understand that they could be their core identity and have the fantasies, desires, and gender role performance that society doesn't usually accept for their natal sex. These children need a place to express these feelings without being further confused by the suggestion of puberty blockers, and I would add social transitions, which makes them have to concretely consider their core gender identity during middle childhood when there's a constant disorganisation, reorganisation, and fluidity in their sense of self. However, there were others who were promoting full social childhood transition. The Australian guidelines, as I've just mentioned, Diane Ehrensaft in 2018 and Simone Giordana in a paper in 2019. And their rationale was that full social transition improved mental health and wellbeing outcomes. There was no harm in doing so. And although some of them acknowledged gender identity could be fluid, they criticised the previous studies showing that most children would desist in their gender dysphoria as they got to adolescence. And Ehrensaft in 2018 expressed a recommendation that the next WPATH standards of care consider early childhood social transition as important as medical transition for adults. And indeed, WPATH-SOC-8 is encouraging of social transition, stating that it should be led by the child and that it fosters a positive mental health. And although it again acknowledges that gender can be fluid, this does not go against social transition. It doesn't cite any the studies that have found no benefit of social transition, does not mention the significant limitations of the study, and does not mention the risk for pre-homosexual children. Then we had the CAS review in 2024, and the CAS review has really in some ways returned to the earlier, when I say earlier, only 10 years previously, more cautious Dutch approach. And Cass commissioned the first published systematic review on social transition and integrated evidence from different sources. And she described there was a lack of evidence of benefit, that prepubertal full social transition may increase anxiety because the child is living in stealth, and there's concerns about it will increase the persistence or artificially increase the persistence of gender dysphoria, and concerns that it would create an sense of urgency for puberty blockers at the first glimmer of puberty. So she recommended a cautious approach to full social transition, suggesting partial social transition as a less risky alternative, and also that there should be clinical involvement in decision-making. So in 2025, what is the state of evidence for the benefits and risks? In 2024, there were two systematic reviews. The Hall et al. From the York University, the Cass Commission Systematic Review, found that it was difficult to assess the impact of social transition due to the small volume and low quality of the research, and the results were inconsistent. From the US, we had Dopp et al., and this found that social transition was associated with improvements in some mental health outcomes, and in others it had inconsistent effects. There were low rates of regret and dissatisfaction, and the evidence was rated very low certainty according to grade. Dopp reported no study found increases in mental health symptoms or decreased functioning, but I actually disagree with their interpretation of the evidence on that. And in 2025, the US HHS report had an umbrella review, and their summary was that the impact of social transition on long-term gender dysphoria, psychological outcomes, well-being, and future treatment decisions remain poorly understood. The certainty of evidence for these outcomes was rated very low. So in sum, the evidence is very low certainty because of study designs. The studies have high risk of bias, inconsistent results, and indirectness. Most available studies are cross-sectional, and the longitudinal studies don't have appropriate comparison groups. And I've added in publication and reporting bias. Some studies, as my next table will show, are not identified by literature searches because social transition findings are not mentioned in the title, abstract, or key words. And my observation is that this is more likely if there's negative or null findings. For example, there was a recent publication by Royal Children's Hospital Melbourne clinicians claiming there was good evidence of benefit for social transition, and they only cited several US studies which have reported this. And they admit mention of the systematic reviews, and indeed they admit mention of their own studies which have found no association of improved mental health with social transition. And furthermore, a letter to the editor written by myself and Gillies was rejected out of hand by the publishers, so the journal was preventing any reasonable debate on this topic. So this is going to be a very busy table and you probably can't read the detail. So my method in this was I collated studies from previously mentioned systematic reviews and did a PubMed search and Google Scholar search for more recent studies, and I added some studies from my own knowledge. And the left column are the studies that the authors claim show an association between social transition and improved mental health and wellbeing outcomes. The middle column, no association, and the right column, a negative association. And as you can see, it does demonstrate inconsistent results. Most of the studies reporting benefits are from the US and particularly from one group, the Trans Youth Project. The new studies, not in the previous systematic reviews, I've put in red font, and they show inconsistent results as well. And although not formally subject to any grade evaluation, they would produce they're low quality and produce low evidence. There are 3 studies from Australia not finding any benefit of social transition or any association. Indeed, one found that the social transition status was associated with worse mental health status in adolescence. So what about the risks of social transition? First thing is it's important to emphasise that no one can predict whether any individual child will have persistent gender dysphoria into adolescence and then into adulthood. But the greatest predictor now seems to be if a child has undergone full social transition. And there's increasing evidence for this. Steensma in a paper in 2013 reported this. From the Trans Youth Project, Olsen et al. 2022 found that 97% of transgender dysphoric children who had fully socially transitioned at a mean age of 6 persisted in trans identification at 5 years later, a mean age of around 11. A more recent study from the same group, Whitland, 2025, report that approximately 80% of the socially transitioned children commenced a medical pathway, and some of the remaining 20% had not actually reached the age where they were eligible for puberty blockers, so this would be expected to increase. And a publication by DeMayo et al. 2025 from the same group support these concerns. This study also reports that some of these socially transitioned children are starting on puberty blockers at an age of 8, as young as 8, and commencing on cross-sex hormones at an age as young as 10. So this seems to support Cass's concerns about an early medicalisation pathway. And these studies contrast with the earlier studies of children with gender identity disorder who were not socially transitioned and in whom approximately 85% resolved before or while undergoing puberty. There's 2 points we should note. First, there is debate about the methodological rigour of these early studies and their findings. I don't have time to go into detail, but one claim is that the old DSM gender identity disorder diagnostic category was broader and included kids who were just only gender non-conforming. But I find this not highly plausible, given how these diagnoses are used in practice. For example, in Melbourne, referral rates of gender identity disorder when using DSM gender identity disorder in the early years of this century, there was only 1 or 2 referrals to the gender clinic per year. But now with the gender dysphoria diagnosis, there's approximately 95 per year. These are prepubertal children. So it doesn't look like the older gender identity disorder was broader. Another issue is that some of the current studies, specifically the Trans Youth Project, does actually not involve any medical diagnosis, whether DSM or ICD. it is the parents and the fact that the child is identifying as trans and that the parents are facilitating full social transition. This is a community group, not a clinic referred group. Anyway, I know some in the audience might have more insights on this debate, and if we have time, we can talk about that formally or informally more. The second point is that, as Cass points out, the current studies showing high persistence for socially transition, because of the study design, can't show causality. They can only show an association. But Cass suggests that it is highly plausible that the fully social transition is changing the trajectory, because she talks about sex of rearing. Other studies have shown sex of rearing does influence eventual gender outcome. This is in children with disorders of sexual development. Of course, there are other complicated factors as well. So, as I've discussed, the evidence demonstrating that without social transition and early puberty blockers, the natural trajectory of these many children was to be homosexual adults, not transsexual adults. We should have really quite serious concerns that early social transition might be unwittingly converting some children who would become homosexual adults to trans adults. We should also think that children with neurodevelopmental disorders may also be more at risk. What are the ethical alternatives to full social transition? Well, we have the old methods of active watchful waiting and psychotherapeutic approaches, and Cass suggested that children should help families to recognise normal development variation in gender role and expression, avoiding premature decisions and considering partial rather than full transition. And going back to the Dutch in 2012, they recommended encourage the child to stay in contact with children and adult role models of their natal sex. Do not prohibit gender variant behaviour, but encourage a wide range of interest. Find a sensible middle road approach. And they said if parents speak about their natal son as being a girl with a penis, we stress that they have a male child who very much wants to be a girl, but who will need an invasive treatment to align his body with his identity if his desire does not remit. Some ethical issues. I actually think it's disingenuous to claim social transition is not a clinical intervention, as some seem to be claiming. It is actually a key component of the gender-affirming treatment model, as outlined in the current guidelines and described by influential clinicians recommending gender-affirming treatment. Physicians cannot abdicate their responsibility to recommend or not recommend this psychosocial intervention by saying parents are doing this prior to presenting at the clinic. Parents are often doing this supported by educationalists based on promotional material emanating from clinicians and prestigious medical organisations. And in terms of informed consent, a prepubertal child does not have the maturity to give informed consent to this intervention, especially as when seen as the first step of a medical and surgical gender-affirming treatment pathway. A child should be listened to and their wishes acknowledged, but they should not be the decision maker. And in conclusion, there is no clinical consensus nor evidential consensus that paediatric social transition improves mental health and well-being outcomes. The studies to date are mostly low quality, producing very low certainty evidence, and the evidence is inconsistent. There is evidence that children with gender dysphoria are now more likely than in the past to have persistent gender dysphoria and start medical treatment in early adolescence. Early social transition is associated with this, however, whether this is causal is not known. The possibility that early social transition is causing an iatrogenic persistence of childhood gender dysphoria incongruence must be considered. And given the existing evidence that we have that most children with gender identity disorder grew up to be homosexual adults rather than trans adults, it also must be considered that early childhood social transition may be acting as unwittingly as a conversion practice for some children, which is of serious concern. And I'm going to finish there so we can have some time for discussion. Thank you.